So welcome to today's session of Healthy Discussions. Before we get started, I have just a few housekeeping notes. The chat box and Q&A feature are both open, so please feel free to use them. You can turn on subtitles, which are auto-generated by clicking the CC button on the bottom left corner of your screen. And finally, this session is being recorded and will be posted to Quality of Care NL's YouTube channel. I'd like to acknowledge that we are joining you from the ancestral territory of the Beothuk, and the lands on which Memorial University's campuses are situated are in the traditional territories of diverse Indigenous groups. We acknowledge with respect the histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We invite everyone to offer land or territorial acknowledgements in the chat and take a moment to reflect not only on why we are offering these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. For those who aren't familiar with Quality of Care NL, we are a research and evaluation program based at Memorial University aimed at improving social and health outcomes in our province. Healthy Discussions is a webinar series where we have quality conversations about health, healthcare, and social systems in Newfoundland and Labrador. Our goal is to engage with you on these topics with the aim of continuing public conversations during the ongoing process of health transformation in our province. Public discussion also contributes to the growth of a learning, health, and social system in Newfoundland and Labrador. On the screen right now, you can see a definition of a learning, health, and social system as defined by Health Accord NL in its task force report. This definition might seem complicated the first time you read it, but what it really boils down to is health and social system that continuously improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, resulting in better care and health for all. Part of the definition states that individuals and families are active participants in all elements. By engaging in sessions like this one, by being an active participant in your own health care and wellness, by talking about and acting on issues that impact us as a society, you are contributing to a learning, health, and social system in our province. Today, we are delighted to have joining us Sister Elizabeth Davis, co-chair of the Health Accord NL Task Force, former congregational leader of the Sisters of Mercy of Newfoundland and Labrador, and current chair of the board of directors of the Gathering Place. Just a few of many titles and accomplishments. We'll start today a little differently than usual by presenting some slides. Later on, we'll share some specific examples of situations relating to someone's health data and information, and we'd really like to hear your thoughts and opinions on those. So please chime in the chat or type questions in the Q&A box. Since today's discussion is being recorded, you may wish to share your questions and comments privately, which you can do by sending it directly to me instead of everyone. So without further ado, I'm going to pass it over to Sister for a presentation.
Thank you very much, Robert. I'll just share my slides here. I want to first of all thank Quality of Care NL for allowing me this opportunity to speak with you, the audience today. As Robert said, I was co-chair of the Health Accord, and following the completion of that report, government asked me if I would do some specific work on one of the elements, one of the calls to action in that health accord, which was the call to look at data governance. Now, data governance doesn't sound like a very exciting issue, but I will assure you that it's not only very exciting, but it affects every single solitary one of us. And as we get deeper into the world of artificial intelligence, we're realizing how much more attention we need to be paying to health information. So I want to start with some slides just to set the context. And then I'm going to use 3 case studies, which are very real, in order to give you some insight into what difference does it make to you, what happens. And we're really very interested today in hearing from you, your perspectives, your questions, your concerns, and your wisdom about what we need to be doing about all of this. I'm saying we because working with me is Donna Roach, and Donna is from within the Department of Health and Community Services, and I'll introduce her a little bit better in a moment. So why really is your health information important? I want to talk to a number of reasons that are quite visible. I want to speak about the health accord itself. I want to speak to you about the new funding arrangements between the federal government and our province in terms of paying for the health system and for improved health. I want to talk to you about an agreement between Canada and the European Union that was actually signed here in St. John's this past month. And finally, a little tiny bit about something I know very little about, artificial intelligence. The Health Accord report was submitted in June of 2022. The name of that report is important. Our province, our health, our future. And the whole premise of the Health Accord is it's an accord, an agreement among the people of this province that our health is not good enough, that there is too much inequity among groups in our province with respect to their health. And to turn this around is going to take a 10-year transformation. Key to that is what this chart tells us. We have for far too long assumed that the health system has the greatest influence on our health. We know from evidence around the world that our health is most affected by the social, economic, and environmental factors in which we live. As low as 60, high as 60%, actually some would suggest even higher, of how healthy you are depends on that. The social, economic, and environmental factors that influence your life, the life of your family, the life of your community. The health system itself may have up to 25% influence on that, and your own biology and genetics about 15%. So if you're going to make a difference in your health, you're obviously going to want to make a difference in the 60% area of influence. So the Health Accord vision then was two-part. It was focused on improving health and health outcomes of all of us, but to do it in two perspectives. The first was recognizing, accepting, and intervening in these social determinants of health. And secondly, rebalancing our present health system among community, hospital, and long-term care services. One of the elements in that health accord referred to information, data and information. And it said if we're going to achieve that vision that I just described, that we have to somehow find ways to link existing information systems across the silos that now exist. And I'll come back and speak more detail about that. We have to improve access to all the partners, including you and me, all of us who are ordinary citizens, ordinary residents of this province. Somebody else holds information about us that is private to us. We need to improve access to that. We need to strengthen the structures within our school system if young children are going to become healthier people. We need to look at how do we track indicators of health determinants? How are we sure that the things we're intervening in are actually making a difference? And all of that has to be done in an ethical, transparent, and publicly accessible manner. And today we're not sure that it is being done that way. What the Health Accord explicitly said, develop a holistic and integrative. Holistic meaning covering all the domains that affect our health. Integrative means somehow it's linked. That includes a vision of how data will be used in this province and to do so in a transparent and accountable manner. It further said that we had to integrate the technology across our systems, both at the micro level, my own personal data, and at the macro level, how our data is dealt with not only for healthcare reasons, but for improving performance and improving our social systems and our health systems generally. Very recently, the federal government made a decision to improve the funding. As you know, in our constitution, health delivery belongs with the provinces. However, there have been funding arrangements between the federal government and our provincial and territorial governments about health funding because it is such a huge cost factor for any province. The federal government then, with the provinces, made an agreement this year, passed in February, starting in February, to focus on 4 particular areas: family health services, health workforce and backlog, mental health and substance abuse, and a modern health data system. So there was very clearly stated in that work that to achieve improved family health and primary health care, to improve the workforce, health workforce environment and engagement, and to pay more attention to mental health and substance abuse, we are going to have to improve our data systems. That was the premise. And not only did the federal government say that we have to pay attention to that 4th area, but it's going to be essential to the funding. You're not going to get funding, province, whatever that province is, Newfoundland and Labrador in our case, if you don't show that you're doing this. And the reason for doing this is to improve transparency of what's happening in our systems, to help us manage future public health emergencies, COVID having been an example of how we poorly managed a public health emergency. But the second point is equally important. How do you and I have better access to our own health information and benefit from it being able to be used across the different other jurisdictions and systems? Very recently, in October of this year, our Minister of Health and Community Services, with all the other ministers across Canada, signed the Pan-Canadian Health Data Charter. And that health charter names some key principles that will guide the action of every province and the federal government to improve health data. It must be person-centric, designed from a person-centric, not a health system-centric perspective. It has to include diverse members of the public, patients, communities, and other partners. It has to support First Nations, Inuit, and Métis data governance and Indigenous-led governance frameworks. Our Indigenous communities see data governance differently than the non-Indigenous communities, and that has to be respected and integrated. We have to find common standards across this whole country, and then across the whole country, ensure quality, security, and privacy. In St. John's in November, the leaders from Canada and the European Union met, and part of their agreement out of that meeting was a digital partnership. And I think that's worth noting as a context that reminds us that all of this conversation about data and information is not unique to this province or this country. What that partnership agreement pointed out, that digital transformation that's happening globally is influencing every aspect of our economy and society. Therefore, that we have to create the vision for how that's going to happen, that a vision that is positive, inclusive, and human-centric. And the design of that system, the development, governance, and use of that technology are guided by democratic values and respect for fundamental rights. They pointed out to the importance of this digital transformation in the economy and growing, sustaining economies. And in that, they focused on artificial intelligence, research and innovation on next generation networks, international connectivity, and cybersecurity. That partnership also spoke to digital identity and digital credentials. We know the computer knows an awful lot about us. Every time you use your computer for anything, that's recorded somewhere in the cloud. So I'm sure most of you don't get the ads I get. I get ads for clothing for larger women and for fountain pens. I'm one of the few dinosaurs left who uses fountain pens, and I have to buy my ink online. So what we see happening then is I keep seeing these ads. Now I'm sure Robert does not get ads for large women's clothing, nor does he get, not being a dinosaur, does he get ads for fountain pens. So why does my computer know this about me? Digital identity, digital credentials. How do we create trust services around this and interoperability? You and I, the ordinary people, became aware of artificial intelligence, most of us, 1 year ago, as of 2 or 3 days ago. ChatGPT was open to the world on November 30th, 2022. That recently, we became aware of the power of artificial intelligence in our lives. We know everywhere you look now, you're seeing AI, but like me, most of you probably have no idea how pervasive that already is in our whole society. And so the challenge, as the Canada-EU partnership points out, is how do we balance the positive effects and potential of AI with the potential negative impacts of AI? Because digital transformation is so pervasive. The report talks about the need for digital language equality. If the digital world had its preferences, it would make English the only language you get in the digital world. At best, you could add a couple of other major language groups. But so how do we protect, for example, indigenous languages in this new world that is being created in front of our eyes? How do we protect ourselves from cybersecurity risks? You know, we had a major risk last year to our health system. So this is not something mythic, this is real. And how all our jobs, all our workplaces are going to be transformed by this. So how do we have a just transition for those whose jobs will be lost because of the digital transformation into this new digital world? And how do we prepare children who are coming on stream now to be working in this kind of economy? And how do we ensure inclusion of groups that usually are left out of major decisions around employment? So data governance is one aspect of this. It's not the only aspect, but it is the overriding aspect. It is that part of all of this that has the big vision, holds the big piece. And so it relates to this. I'm using this model from the United Nations because it's so comprehensive, but it starts with basic principles to which we all agree. How do we classify data? How do we ensure quality of data? How do we are very careful who has access and who cannot have access? How do we deal with the life cycle? At what point? It was easy when we had paper files to say after 10 years you can destroy these pieces of paper. But if my data has been shared with 5 or 6 or 7 others through the computer, I can delete it from my computer. But now Robert has it on his. How do I make sure that it also got deleted from his computer? And whom did Robert lend it to that's on their computer? And finally, who can use the data? So that's what data governance does. It doesn't do those pieces. It oversees how these pieces unfold. So in the work that Donna and I have done then thus far, we've seen some issues that we need to address. The Health Accord said that whatever we do around health now, we have to do both with health systems and social systems, because the justice system, the education system, social services, the Department of Environment, all have more to do with how healthy we are than the health system does. And what we know is that health systems come from understand health information in a very different way than social systems do. They have very different kinds of systems set up in the first place, and they look at data very differently. They are not connected one with the other. A good example of that is a little child going to school, 5 years of age. If that child has medical challenges, which more of our children do on average than children in the rest of Canada, how does the health system speak to the justice system, speak to the education system? Right now, they don't. I mentioned earlier that Indigenous peoples look at how you govern data differently than people who are not Indigenous. How do we make sure that we find that balance in our work? The public, including me, and many people working in the health system and social systems are not data literate. We don't understand a lot of these issues. How do we increase that awareness? Genetics data is particularly challenging because if you have my genetics data is not unique to me. I share it with anybody with whom I'm biologically related. So what does person-centered mean in that situation? Another challenge around genetics, in this province, we have a wonderful genetics laboratory because we were so long without mixing with other groups. So there's much research that can be done in this province to help us. There's much genetics related illness in the first place, but also much to be learned from research in genetics. But researchers have a different approach as well to data, how we work with data, than do clinicians. The clinicians in the health system are held to one standard. Memorial University, which is primarily the group to which the health researchers, genetics researchers belong, have a different approach. How do we work that through? And now with artificial intelligence becoming so real among us, how do we oversee that when it's so much beyond most of our comprehension? We're not the only one. Unfortunately, all these issues everybody has, and nobody has the answer. There's nobody we can go to who's figured this out to give us the recipe. And I just use a couple of examples here to prove my point. The federal government is spending a lot of time and energy on this. They have on the books now for a couple of years, Bill C-27, that has within it 3 different acts. One related to consumer privacy protection, another to artificial intelligence, and another to personal information and data protection. They're working through the implications of those 3 acts, but we're not anywhere close yet to getting these acts passed in our parliament. Just a month ago, President Biden in the United States issued an executive order, relatively rare, focusing on artificial intelligence and managing the promise and the risks of AI. Standards for safety and security and privacy, advancing equity and civil rights, standing up for consumers and workers, promoting innovation and competition, and as you'd expect, advancing American leadership around the world. In mid-November, just 3 weeks ago, the United Kingdom held a major AI safety summit. Very same issues, and they involve government representatives, people from universities, businesses, and the community, civil society, talking about how we navigate the risks of AI, ensuring the potential benefit, but also protecting against the potential dangers. The European Commission has the most advanced legislation and regulatory framework proposed at this point. Their system is so big, they imagine it's going to take 3 to 4 years for that to work through their system. But it's also focused on how we keep the AI system safe, transparent, traceable, non-discriminatory, environmentally friendly. And now the partnership between Europe and Canada shows that we have common goals, common vision, common ethical principles in the doing of that. Even the Vatican City is involved in this. A group in the Vatican has signed partnership with Microsoft and IBM, also signed with the Jewish and Muslim leadership for a call for AI ethics. And they have invented a new word, algorithmics. AI works through algorithms, so it's a play on that term. So they've invented the term algorithmics to talk about how we have an ethical approach to AI, and the values they've named are the same ones the others have named: transparency, inclusion, responsibility, impartiality, reliability, safety, and privacy. In other words, all of these groups are working with the same impetus, the same urgency, the same awareness, and the groups I've identified, the same vision that we would have. So the challenge then is recognizing that data and information are incredibly important public assets if we're going to deliver proper health care, if we're going to make informed decisions about our health outcomes, and health equity, if we're going to monitor the performance of our health and social systems, if we're going to enable research and innovation, if we're going to engage and empower you and me, the citizens of this province, with access to our own health information. And at the end of the day, the goal of all of this, if we're going to improve health and health equity, we have to figure out how to do this. We do not have the luxury of sitting back and waiting until Europe figures it out, or the United Kingdom figures it out, or the Vatican figures it out. We have to be part of this conversation, and we have to be prepared to put things in place that are not perfect in order to help us figure out how to improve them as we move along. With that in mind, then, there are 3 studies that we want to talk with you about, just to get perspectives from you on what you see alarming about this, what are the questions you would have about this, how you would approach any of this. So the first study is a real, a person is not identified, but it's a real situation. Not only is it a real situation, but it actually happens many, many times, far too many times in this town. Sally is in grade 3. She lives with her foster family, but she's still in contact with her biological parents. So there's something happened in their home that she had to be taken from her home. She has ADHD and is taking multiple medications. She and her family receive services from her guidance counselor at school, her social worker through CSSD, and a number of healthcare providers from the health system in the province. So the education system, the teachers who are teaching her, the social workers, and not only the teachers, but the guidance counselors, the social workers, and the clinicians at the hospitals, in the hospital system, are all providing services for Sally, and they need to work together. But right now, they don't work together. None of their health systems, none of their data systems can talk to each other. And very often they're very loath to even share data in any way. So have you got any insight into any of this, any questions about it, any concerns about it? So I'll just stop sharing for a minute and see if there's somebody who'd like to add a note or a comment on that particular situation, which happens far too often in this province.
I'm not seeing anything right now, sister.
Just to say to you that this, as I said, this is so important in this province that actually so very rare for us, the privacy commissioner and the child youth advocate wrote a document about this kind of situation. I just want to show you the face of that document. The name of the document is Yes, You Can. And the document was released 2 years ago in December 2021. They were so distressed about the fact that the child and youth advocate was so distressed about the fact that teachers said to her that they couldn't share or receive data with the nurses who were working with those children or the social workers. The nurses were saying the same thing. The social workers were saying the same thing. So all 3 groups were quite worried that they couldn't share data about people like Sally, with Sally or her family. And when asked why they couldn't, they said the law doesn't allow them to. the Child and Youth Advocate went to the Privacy Commissioner, who said, that's not true. So they wrote this document called Yes, You Can. And what this document does, as it says, it dispels the myths about sharing information. Now, even if they get past the myth of sharing information, as we stand today, they don't have the capacity, actually, technological capacity to share the information. Systems can't talk to each other. But at least we're getting to the point where they may be able, we hope they're hearing that they can share the data. Did I see a comment there, Matthew, Robert, from Melissa?
We got a few. We got one from Deanne saying it's inefficiency in providing service. Holly wrote down issues around where data is stored and who can access what. There's also questions around who is ultimately responsible for starting conversations / sharing info about this child or any child. And where can we find a copy of this document that you just shared? Yes, you can. We can perhaps put that in the link if possible.
That's very easily accessible online.
Okay.
So if you put that in, Robert, I appreciate that.
Perfect.
The three questions, well, Diane's question first, that very definitely, it's not only inefficient, it's also ineffective. It's not good for Sally not to have those three providers on this, at least knowing what each other knows, so they can find a common pathway forward. So that's absolutely true. It's very common in this province because, as I said, of all the provinces in Canada, we have the highest percentage of children under the age of 5 with medical disability challenges. So it's even more serious here than other provinces for that reason. Holly's point is very true. Nobody knows the answer to Holly's question. Where is the data stored? How is it accessed? Because every one of those providers does it in a very, not only different type system, which is one thing, but there's a whole different approach to what they value as data, what's captured as data, how it's captured, no unique identifier. I remember once at St. Clair's when we were bringing in the information system, the man came from Ottawa to work with us, and the sister at the time was in charge of medical records. And she said to him, "Are you going to solve my problem?" And he said, "Sister, what is your problem?" She said, "I have 47 Mary Murphys in my health records." 47 Mary Murphys. So we are a province, because of our limited intermixing until recently, we have a lot of Mary Murphys and Jim Powers. So how do we resolve that for Sally when not only does the health system name Sally differently, records different data about her, to the extent that the other systems have it, the education system and the social system. So Holly's question is a very important question because it can't be answered right now, and we should be able to answer it. The third point was, I forget the third question.
I'll scroll up. One was actually just around where we can find this document, but there's some more comments coming in. One from Doug. It's a bit worse than that for Sally, since her problems may have been detected in her preschool years. Information may not be passed earlier.
Exactly. And that's a real issue. That's a real issue. And in Sally's case, where she has two different groups of parents involved, that is even more problematic, because if she was taken from her home, there's a high chance that not only was safe social services involved, but the police will maybe have been involved as well. And nowadays, particularly, once a child is taken from the home, it's not done lightly. So you're very correct that this is quite complex.
And Chris has a comment and question. The problem is that information shared may have more than just her condition, and that is invading privacy. Does the patient have to agree?
And this is a very good question. Sally's a patient, a client, a student. Sally has many identities. She's also a minor. So who has the right to gather the information for Sally? Who has the right to stop information sharing around Sally? Because it's never going to be just around her in this instance. these are questions that because everybody approaches data differently, everybody collects different kinds of data from the groups we're looking at around Sally. There is no straightforward answer to your question. Whose privacy is paramount? Which one at the end of the day takes priority, and who makes that decision? So that's complicated enough around Sally. If Sally is also Indigenous, it is even more complicated, because in Indigenous approach to data, the community also has a voice and a place. So we don't have clarity around that. Everything you're saying is the reason, somewhat in desperation, that the Privacy Commissioner and the Child and Youth Advocate sent out their document. And I really encourage you to read it, because both of them did a very thorough mining of all the existing legislation on the child and youth side, protection side, and on the privacy protection side. What we're learning from the EU is privacy by itself is not an absolute. It has to be balanced with other priorities. And so most people, what we're learning as well from work that's been done, most people would not trump privacy over everything else. They put other things ahead of privacy when you actually speak to them about it. So what's beginning to happen in the privacy world is they're starting to talk about how do you measure the risk of breaching privacy, among other things. So they have layers of risk. Like there's minimal risk, there's maximum risk, which was a no-go zone, and then the piece in the middle that has how do you balance the risk. So that approach is the one we're being encouraged to see through now. The EU has that actually built into their legislation. The layering of risk and how you manage the risk in each of the zones. The red zone you don't go near. The green zone is you don't even need to get the person's permission. It's the in-between zone that's unclear. So a lot of new work is being done on that, just as person-centered no longer means what it meant in the past, because of what genetics is doing and the Indigenous approach is bringing to us. So too, privacy has to be mitigated. So a very important question, Chris. Thank you.
Sister, I got another question, but before you get on that, can you perhaps, just where you started talking about some databases that perhaps had multiple people with the same name, can you just kind of talk to the importance of data quality? Because it's an issue within research and evaluation that, data is prone to human error. And sometimes information like something that's an identifier, like a name, can be entered in multiple different ways, with initials or a name shortened. Can you just kind of speak to the importance of data quality?
Absolutely important. The challenge you have is what data are you being even looking at for quality, because what are the questions being asked? From where was it gathered? How secure was that data that you gathered? What we also know in this province now, and from the health side, we've migrated to the MCP number. In my lifetime, we've kind of gone all over the map on that. We used first we had the hospital numbers, then we had when we created the regional health authority numbers. Now we've migrated to the MCP number. The MCP number has its own flaws, and we're aware of that. So even looking at the number, how quality-based is the unique identifier. This is where digital identifiers and digital credentialing becomes very important. And how do you use that again with the varying level of risks that go with having, I'm old enough to probably only very few of us on this call remember when we introduced the social insurance number, which was meant to be the unique identifier for all Canadians. And there was an immediate backlash to that. The Big Brother syndrome, the absolute invasion of privacy. So 2 points about this. One, the computer, as I said, already identifies me and knows my clothing size and my fountain pen type. So it knows the 2 most important things about me to be known. I never gave a permission to know you to distribute that information to anyone, by the way. except to the group I bought it from. So but how often do you distribute your data, Robert, for example? You probably went in on Ancestry dot whatever to see how much of your part, whatever,
Yeah.
Norwegian or something. You know, we share data in funny ways and never even think twice about it. Don't realize that once it's there in the cloud, everybody has access to
Well, I know what to get you for Christmas now, and
it.
so I'm just mindful of time because I know you do have a few
We
more
have two
examples
more
to
that
give,
you
but yep, sure. I'll just give. There's one question here: is personal and professional ethics are very important in this project. Is there a monitor as to what is accessed and how it is used?
No, the answer, simple answer is no, and should there be, yes. What again, it's a funny thing about artificial intelligence, but like when you introduce something so big and new, it puts a spotlight on what we were already doing from pre that time period. And we haven't been doing proper education in those areas. Education in two ways. One, education about the safety of the data and the protection of the data, but it's also about the use of the data. So if you're collecting data and you're not using it, you haven't got time to put it in because you're too busy saving somebody's life or doing the urgent matter of the moment. So you forget to put it in, or you put it in 2 days later and it's not quite accurate, but fairly close. So you're ending up then inputting poor data. Now, artificial intelligence gathers millions and millions of pieces of data and then draws conclusions on it. What about if 80% of the millions and millions of pieces they draw are biased? And we have lots of evidence of that around artificial intelligence. So if you're white male in facial recognition, the chances that it'll be pretty accurate. If you're black male and white female, it's fairly accurate. If you're black female, it's totally inaccurate for just for facial recognition. So if I'm robbing a store, if Robert robs a store, we have a best chance of getting his proper facial, and therefore everybody else not accused of it. Somebody like looks like me robs a store, the chances aren't good that I'll get mixed up with them. If I'm black and female, the chances are high that I'm going to be pulled in even though I had nothing to do with it. So AI only gathers bits of stuff, and if enough of those bits of stuff are biased, it intensifies bias. So that's why I'll move to the next story.
Sure.
Is real. This one is actually in the public domain, so it's not, the names are not protected here. And you probably know this yourself from, sorry. You may know this from the media. It's a case that happened in the Netherlands. And in the Netherlands, a woman in 2012, Charmaine Lensner, was a social work student with 3 children under the age of 15, up the age of 6. She received a letter from the tax authority requiring her to pay back her child care allowance for the last 4 years. That was €100,000, close to $200,000. He recognized it was an error. It took 9 years to solve that problem. 9 years. The tax authorities had used a self-learning algorithm to create risk profiles to identify citizens most likely to defraud the Dutch government. And that wasn't made public till 2019. So it happened in 2012. So she received this letter. She was blacklisted based on this learning algorithm that was inherently biased. In 2019, and the government fell over this, by the way, thousands of parents were falsely accused of fraud by that tax authority because of the use of the algorithm. Most of them were low-income families, and a disproportionate number, as you'd expect, were ethnic minorities or immigrants. The consequences were devastating, and you can look this up. As I said, it's in the public domain. Allowances were taken away, families were left homeless, children were separated from parents. A number of suicides were directly attributed to this situation. And it happened, it was over a 9-year period before it was resolved. So over that 9-year period, these terrible consequences were happening. Nobody knew that that algorithm had been used or how it had been used. And as I said, once it became public, the government fell over it. So this was, the Dutch government wasn't setting out to cause people to commit suicide or to cause people to lose their children, but that was the consequence of what had resulted from an algorithm that took all the data, biased against minorities and immigrants, particularly, and refugees, and that's what it led to. So any thoughts on that? So away from the children example, which we saw as complex, this was a hugely complex issue. Any comments or questions on the potential of this versus obviously the risks of this?
Nothing popping up right now, but I will speak to a comment that was made. This effort should not be led by medical and government alone, but by a committee of citizens who advocate for privacy and citizens at large.
Yeah, and that's a huge issue, right? With the children's one, you sort of have a way in to talk about it. But how do we, Chris said, this way outside our pay grade? It certainly is. But what right today, do you know if our government is using such an algorithm in social services? I don't. So the question becomes, how do we ensure as a public that the government and all the, not only government, not only public sector organizations, but private sector organizations too, how do we ensure that the users of my data in this province are going to not use them in a way that will inadvertently, in most cases, hurt me? So how do we have any assurance of that now that we have the cloud technology and now that we have artificial intelligence? Where do we get our voice? Any thoughts on that? Because this is a dilemma for Donna Roach and me as we prepare our study. How do we do this in a way that's real, in a way that's able to be managed?
There's a question in the chat, sister. It says, "Isn't this a place where AI could be especially useful in a forensic sense? And AI is able to process vast amounts of data from far more efficiently than humans alone."
Yes. Absolutely. Unfortunately, as it showed in this case from the Netherlands, it took the data that was already inherently biased and intensified the bias. But you're right. It's an irony. When I started to hear about ChatGPT and didn't understand it very well, I asked Dr. Randy Giffen to explain it to me, and he sent me the explanation that he asked ChatGPT to give me about what it is. So it was the best way he could find to explain it to me. But you're right that the problem is, how can I trust it when it's so foreign to me? It's so close to me in terms of my information, but how can I trust it when it's so far from my knowledge base? So how do we create the bridges between such a mysterious kind of a reality and the ordinary citizens whose lives are going to be affected by this? And as Randy Giffen said to me, sister, we can't ignore this. Like, the safest thing is not worry about it. But he said big companies are worried about this. Google and Microsoft and IBM and Meta are all into this. China and Russia are into this. So if we're not in this game, we're going to, by default, be even more compromised. So how can we imagine ways of bridging the gap between all of us who know hardly anything about this and those who are thought leaders in it.
There's a few more comments and questions. That must have completely destroyed trust in the Dutch government. Once trust is lost, it is difficult to earn it again. I understand the government fell, but how do organizations recover from errors like that?
Yeah, and it's huge. I mean, anytime there's a breach of privacy, it doesn't have to be as big as that one was. That's one of the most serious that we're aware of. And in a country very like Canada, ironically, a country just last week who elected a far right leader. Another strange kind of reality. But so that's the dilemma I'm facing, and what I'm going to ask you at the end to put um, into your comments ways that I can be recommending to government of how we do bridge that gap. How do we help? If when the cyber attack happened to our own Eastern Health Organization, it is taking a while to trust privacy again in Eastern, now Newfoundland and Labrador Health Services. So I don't know the answer to that, but I need to be able to get from you ways to answer that question. Definitely. I'm going to do the third example with you, if you don't mind. Everything you're putting in the chat, Robert and Melissa promised
We'll
me
capture it, yeah.
they're capturing. I'm just going to give the third example because it's so relevant again for our province. So that's around genetics. And this is particularly challenging because genetic testing has skyrocketed, as we know, since 2003. And that's the marker of the date when finally the human genome was decoded. So since that, the ability to predict a person's risk of getting cancer or hereditary disease has improved quite significantly, as has the ability to detect and treat a genetic illness. So in 20 years, we've had an amazing potential for help here. But then I give you this example. Sam's physician has recommended that he have a genetics test that could save his life. He refuses. When asked why, Sam says that the outcome of the test could mean that he or his children could face not being hired or promoted, could be prevented from traveling outside the country, may not be able to get life insurance or health insurance, or have access to childcare. He says the risk is not worth it. So this is a person who has the potential to have a hereditary disease. The doctor tells him that they now have a test that can say what his risks are going to be and give treatment that could save his life. And he says no. Because once he knows he has the disease, if he finds out he has the disease, the risks to his children then are clearer. And then he has these other potential risks. Even if he doesn't have the disease or can be treated for it, the potential risks are so high that he's not going to take the chance. Another similar example of Susan. Susan knows she has the disease and she has adult children. The doctor says to her, Susan, you need to tell your children now that you've been diagnosed with this illness so that they can get tested. And Susan says no, because my disease there's no cure for. So why will my children not be able to get health insurance? And she gives the number of these examples again. Nobody will trust them to give them a promotion in the workplace. So we can't figure, in that case, there was no cure possible. So why should I even allow them to be exposed to those risks? I'm not doing it. So what would you do if you were Sam or Susan and you have adult children or small children even? How do you even get your head around? And this is not rare in this province. This is not something That's not likely to happen at anywhere in this province. It's actually, as you know, genetic illness. There are several, I know, in the Davis family. We're one of the families in the province that has a genetic propensity to pulmonary fibrosis.
There's a comment. There are laws to prevent release of that data to insurance companies and employers. It has been discussed in Canada. Not sure where that ended up.
Yeah, there is a law in Canada that no insurance company can ask for or receive that data. That law does exist in Canada.
There's a question from Frank. Is there a particular reason the doctor is recommending the test? Does the test indicate the likelihood of one condition or illness?
Yeah, and these are the kinds of questions you need to ask. And if it would be for a particular illness, and therefore if there's no treatment possible, that's a different kind of a dilemma than if you do know there is a treatment possible. So these are the point you're making, Frank, is a very important point, that you need to have more information before you may face that kind of decision. So the physician has to be able to be aware of the complexity from your perspective of even raising the issues with you, and then be prepared to give the answers.
So there's another question. Unfortunately, Sam is probably right, but it shouldn't be this way. What can we do?
Exactly. And as I said, in this province, this is not totally a mythic. Most of us will know a family that is linked with some genetic illness. So we have to be able to, and I'm glad somebody like Holly is on this call, because we need to have ethicists who help us talk about these dilemmas and help us think through all the implications of these issues. How do we link physicians, other clinicians, and researchers in the unfolding or leading in the conversations around these kinds of dilemmas? We don't do that. Like we don't foster those kinds of public conversations around such sensitive issues. But we need to. We need to, because until we keep doing that, we're not giving back the power to people to make decisions for themselves. You know, the day of whatever you say, doctor, should be gone. You know, depending on somebody else to make a life decision for me or my children, this shouldn't be real anymore.
So I was going to make a comment, but Holly pretty much summed it up here in a comment that complicated issues surrounding duty to warn, right to privacy, and making one's own decisions. There have been situations where clinicians can override the parent's choice not to know if lives of adult children can be saved. Research in the UK has piloted sending a letter to Sam or Susan's family advising a mutation has been identified, but not identifying who exactly has it. The family members are offered testing. That project showed that the letters were very well received and many relatives did come in for testing. Because it is that barrier of how does that parent, if there is adult children, how does that parent have the right to refuse information for the child?
And yet today, that parent in this province has that right. So that's thank you for that. I just noticed, I think that there's a form coming up. Robert might just read that out before I give my last.
Sure. It says Health Data Research Network Canada is planning a public forum on the 23rd of April of 2024. It's a hybrid event, theme of which will be health data for all of us, earning trust through transparency. And Catherine said she'll send us the invitation when it comes out in early January. So perhaps we can share that with who registered here as well.
So if I might then show my last slide.
Sure.
Given that we're running out of time. So I know that this is the beginning of several public conversations Donna Roach and I are going to be leading to help us prepare our final report to give to the minister. So the questions I have for you, and I hope you'll take a moment to write something in the chat. We won't have the time to share them now, but I'll get them from the chat. or if you would email me directly, I'd appreciate it. How can we engage members of the public in conversations about the use of health data and information? We, it's not something, data governance is really not something people talk about at breakfast table. But when we look at into the issues themselves, we realize how important data governance is around those issues. How can we get both the wisdom and the concerns from members of the public about proper governance of data? And how can we involve not only the initial to help my work in my report, but how do we involve people in the ongoing structures that we create to oversee what's happening with health data and health information? This is a moving target. As AI becomes even more pervasive in our society, these issues are going to multiply intensely. And as I said, 1 year ago, most of us had no idea how pervasive AI was in our world. In 1 year, we've gone from 0 to 100 just in 1 year. So we no longer can say, okay, this is the answer, do it, and it's finished. Now we can say, this is the answer for today, but it's built in flexibility for tomorrow. So needing to do that is a very important piece of work that we as a province have to do to be much more literate about the issues, much more engaged in exploring the issues, and much more intentional about protecting and properly using, because not using the data is worse, as we saw with Sam's children. His adult children not knowing this is much worse than they're knowing it. Although Sam answers the question differently, he says they're knowing it is much worse than that. So how do we have those conversations, and how do we build in structures to allow the public not only for their own information, but to set up the systems that protect us? So I would appreciate any information you can provide to me and Donna. At the end of the day here, the goal is to improve the health outcomes for the people of this province that are not as good as other provinces in Canada. Inside our province, we have terrible inequity in health that should be addressed. We need an ethical, robust, responsive data governance structure within the learning, health, and social system that Robert described at the beginning. This is the only way we're going to be able to improve health outcomes here and make sure that our equity around health is even and fair right across the province. My email is edavis@sistersofmercynf.org. If you want,
we can put that in the chat, sister, just before we clue up.
If people want to send me anything, I'd really
sure. And there's some great comments in the chat room, just giving some links to Health Data Research Network, which gives some great resources for public engagement, and there is some great feedback that we'll share with you, sister. I am mindful of the time right now, so I'm going to clue things up. So thanks for today. For today's session, I want to thank Sister Elizabeth for leading us through a great discussion on this important topic. A big thank you to everyone who joined us online to listen and participate in our discussion. And just a reminder that a recording of this session will be on our YouTube channel in the coming days, and you can check out the recordings of all previous sessions there as well. Stay tuned to qualityofcarenl.ca for an announcement about Healthy Discussion Series for 2024. We're working on some great topics. Lastly, you'll see a very short post-event survey on your screen after we end the webinar. We'd appreciate you providing any feedback or ideas for future healthy discussions. And thanks again, everyone. Have a great day and a lovely holiday season.
Melissa and Robert, thank you so much for.
Thank you, sister.
Making
Always
this
a pleasure.
happen. Take care.